On behalf of the INSITE Center for Business Intelligence and Analytics, I'm very pleased to extend a very warm welcome to all of you. We are very pleased to present our second annual symposium. INSITE Center is the Big Data Analytics Center, Research Center here at the University of Arizona. My name is Sudha Ram. I'm a co-director of the center, along with Paulo Goes, who's the department head of MIS. It's our pleasure to present our themed symposium this year on using big data for predictive analytics in healthcare. So healthcare is the theme. We have a very exciting agenda. I'd first like to thank our sponsors, Banner Health. Is there anyone from Banner Health here? Thank you very much. We welcome you. We're very honored to have you here, and thanks for your sponsorship. And also to the Eller College of Management, Len, thank you very much for your sponsorship. I'd like to give you a little bit of information about the center. This is our website. We work on a lot of interesting translational projects using big data with a variety of partners, and healthcare is a particular area of interest to us. So if you're tweeting today about the symposium, please use the hashtag #InsightBigData. With that, I'd like to introduce the co-director of the INSITE Center, Paulo Goes, department head of MIS and Salter Distinguished Professor. Paulo, welcome.
Thank you, Sudha. Good morning, everyone. My pleasure to be here welcoming all of you to our second Big Data Symposium. This year, we decided to focus on healthcare. And the interesting thing about big data is that we've been working on big data for a few years now. As the MIS department, we are very good at information management, data integration. We're also very good at creating that layer that transforms data to knowledge, data, information, knowledge, intelligence, which now is being called analytics. So we've been working on these topics for a few years. And of course, everybody now is talking about big data. So as head of the MIS department, I have constantly I'm invited to participate in committees and groups around the campus about big data. And the first thing that you notice is that everybody has a different definition of what big data is. So everybody has a different understanding of what it means. So when you think now about healthcare, which is this very interesting area, very interesting industry, where you have a number of stakeholders, from patients to doctors, to healthcare providers, to insurance companies, to hospitals, to the government. And everybody has its own definition of what they should be doing. The data sets that you can think of that relate to healthcare, they also represent a multitude of different types of information, from electronic medical records. You've experienced this digitization of processes generating all the electronic medical records. You have behavior data that you can acquire from different sources, including social media. We have a presentation today related to that. You have data coming from the Internet of Things, the sensors, everything generating so much data. You have genomics. So you have all these different data sources. And the question is, what can you do with that? Going back to the definition of big data, some people think that, okay, I already am sitting on these massive amounts of data. What can I do now? And then there is the other category of people who they understand, they know what they want to do. Like in healthcare, they want to lower costs, they want to increase quality, they want to manage outcomes. But then they don't know how to gather the sources to be able to do that, the data sources. So I think a symposium like this, where we have representation from all different stakeholders, including all of us are patients at one point or the other. You have physicians in the audience. You have people representing different healthcare providers, academics. It's a great forum for us to be discussing and educating each other about the challenges and how we can do things. MIS, my department, is about connecting. So I think here the symposium will play that role of connecting people, connecting different constituents, and having a better understanding of the area. With that, I also would like to thank Banner Health for their generous contribution that make it possible for us to host this. And I'd like to thank my dean, Len Jessup, for his support as well. And I'd like to ask Len to join me here to say a few words. Thank you.
Thanks, Paul. I'll be brief. I just have a couple of quick comments to make. I was sitting there, though, realizing that it was not that long ago that I was a graduate student in MIS in this program here back in the late 80s. And so walking into an auditorium like this to hear speakers in MIS, including Suda, makes me sweat a little bit. I kind of think back to being in school here. It was not that long ago. And I noticed myself trying to peer over Andrew's shoulder to see his notes, to see what he was going to be talking about, to see if it might help me with my remarks. It's a great pleasure to be here and to welcome everybody. This is, I can't think of a better thing to apply big data to and Suda's work to than healthcare. Suda talks about in the definition of, she reminds us it's not with big data, not just about there being a lot of data, but that it's complicated data and that the velocity of the data is high and increasing. And I can't think of a better way to describe data in healthcare than that. As Paulo mentioned, all the way from heartbeats to coding on a billing and everything in between. A lot of complicated forms of data being created at a rapidly increasing rate and coming at us at a rapidly increasing rate. So really excited that we're focusing on healthcare this year. And I also wanted to just quickly underscore something Paulo said, that the point for us doing this symposium is it's about collaboration. We've got a very good, highly ranked MIS program, and it's got engines within it like the INSITE Center, and they're causing a lot of collaborations across campus and even outside of academia between our MIS department and corporate partners. And we would like for more of that to happen today. So you all have my permission to talk to anybody in the Eller College that is in here about any way you would like to connect with what we're doing in the INSITE Center and really anything going on in the MIS department. That's the point of this for us, is to have more collaboration. And then finally, I just wanted to thank Banner also. We're not able to do things like the symposium. We're not able to do things like INSITE, and our MIS department isn't able to be a top 5 MIS program year in, year out without the help from companies like Banner and from individuals that help to invest their time, treasure, and talent into our program. So thank you again, Banner, for sponsoring, and thanks for giving me the time, guys, to come up and say hello and thanks. And then my final act of the morning is to introduce my boss, Andrew Comrie, the provost at the University of Arizona. And I was just kidding about peeking on your notes. I didn't actually do that all the way. Andrew Comrie.
Not much to see in those notes, not really. Well, first of all, thank you, Len. And I will echo the thanks to our sponsors, Banner. Thank you so much for helping out with this. I also want to underline the excellence of the department and college that are behind today's session. We're sitting here, obviously, in the leading academic medical center here in the Southwest. And we have what I would like to think is the leading business school in the Southwest, just a quarter mile away. And in that business school is an MIS department that, as you've heard, is a top 5 department. And we have literally the world's experts here on management information systems. And some of you may have no idea just what sort of demigods we have here in Suda and Paulo, for example, and some of the speakers that you'll hear. These people are just phenomenally huge in their disciplines. And I couldn't be prouder to be just making a few remarks and being able to brag on the talent that we have at this university, and really admiring the way that this particular symposium has been put together. So I'd actually like to welcome you all on behalf of not only President Hart, but all the faculty at the university, not only in Eller and here in the health sciences, but the entire university. As you'll hear today, while certainly big data touches healthcare, It touches everything these days. Because we have basically digitized our entire world, everything is up for grabs for big data. And in fact, I would say maybe some of the most interesting challenges in big data are the intersections of these different families of data. So where healthcare meets social network data, or where social network data meet financial data, or where travel data meet healthcare data. You can just imagine all those combinations. And I know in talking to some of these scholars offline that some of the most challenging problems in this area and some of the most exciting potentials in this area come from those intersections. So prepare to be stimulated and to really have your mind bent about what some of the true possibilities of this approach can be. Big data is such a big deal. In fact, as Paolo was saying, it's such a sort of an in term now, you sort of wonder what it really means anymore. And everyone has their own definition. But it is a big enough deal that everyone is doing it. And in fact, even here at the U of A, we just recently launched some cluster hiring initiatives, and one of them is in big data. And my challenge to the group, and I suspect that these folks will be heavily involved in whatever comes out of that initiative, is what's our niche? What is the U of A's angle on big data? Because frankly, it's too big for any one place to take on. What sort of spin will we be putting on the big data area? I happen to be trained as a climate scientist, where we've worked in things that we would now call big data for a long time, and the challenges are immense. The kinds of problems that you approach range from the sort of mathematical theory, computational theory, all the way down to theories of how decisions are made or how you can extract information from data sets that you didn't even know was there, versus finding needles in haystacks when you know the needles are there and you don't know how to find them or even quite what their signatures are. All these problems are a key part of this area. And we need to know which class of activities we're going to become the world experts in this area of big data and predictive analytics. So it's a key area, not just for the interests in the groups assembled here, but it's a key area for the entire university, because this touches everything we do also, not only operationally, but of course in the academic realm. So healthcare. The emphasis on healthcare here today is propitious because those of you who have kept in touch with what the university is doing know that we have a huge initiative going in upgrading our healthcare profile. In fact, our sponsors today, most of you know, we are in some fairly detailed end-stage negotiations with Banner about a major new partnership that will be transformative to our healthcare operations, and at its heart will be all about the impacts of big data to improve healthcare. So not only do we have an emphasis in understanding how we can be best in different aspects of big data, but we have an immense interest in making sure that we elevate our healthcare operation here and all the associated research and academics to the very best quality we can in partnership with some great partners. So I guess I've underlined for you that this is absolutely front and center for the University of Arizona. Now, we mentioned MIS, we mentioned the INSITE Center. These are things, they're great ways to package what we do into market, but I just want to underline again that at their core are world experts like Sudha and Paolo and their colleagues who have truly broken the barriers, and that for those of you who are not from this field and are here today to find out more about it, I can assure you that these truly are some of the world's experts that you're going to hear, and that you are going to be as up to date as you possibly can in this area once you hear what the proceedings have to offer today. I can't say enough how insightful that you're going to find the views today. I'm actually just sorry I can't even stay for the whole day, because as you can tell, this is something I'm actually quite interested in. And I know I use big data in my work every day, and I wish I had faster, better, more accurate tools than I do right now. I get the reality of real data systems to deal with, not just the ones we hope we're going to have next year. Finally, I just want to say that the collaboration point Len made can't be underlined too much either. This university has made its name on collaboration and having very low walls to partnership and to working together. And really the single biggest obstacle to making those kind of collaborations happen is that first conversation. So I encourage you all to talk to your colleagues here, to introduce yourself to someone in the lobby when you're feeling like you don't know anybody. Go up to someone, say hello, and make a connection. There's no digital substitute for that. And that human networking is what makes the strongest collaborations and will produce the strongest outcomes here for everybody. So I strongly urge you to make sure that you break the wall of communication, and you reach out not only to the organizers and the speakers, but to other people in the audience to find out what everyone's doing. That's how the big discoveries are made. That's how the big advances are made. By meeting people who have an interesting problem that you can solve or they can solve for you. With that, I enjoin you to get the most out of the day. And as I say, welcome from the whole university, from our faculty, our staff, our students. For those of you from off campus, for those of you on campus, it's delightful to see you here. And have a marvelous day. And thanks again to the organizers for putting on another excellent symposium. Thank you so much. Now I'm going to call Sudha back to the podium, and I warned her ahead of time I was going to embarrass her. We already heard, Paolo has a distinguished chair. He is the head of the department. Sudha's no slouch either. And if Paolo got hit by a big data bust tomorrow, all eyes would probably be on Sudha to be doing what he does. Sudha's area of expertise spans this whole area of big data, but in particular, she's recently become known for the intersection of what you can find out from social network data. She mentioned the Twitter hashtag earlier, that was no accident, and how those data intersect with everything else we're doing, because those are one of the newer forms of data, and then perhaps one of the most revealing. They're also, if I understand your field right, one of the messiest forms of data that we know about out there, and some of her expertise is how to kind of demessify, if that's a word, the data and look for signal in big data when most of it appears to be noise. When you've got a big hairball of numbers and you don't know what quite is in there, and yet you know there's something there, it requires a phenomenal brain to figure out the smart ways to find what's in there. And Sudha is one of the people who has done and is doing exactly that. At some point, catch her today and find out all the cool things that she is doing research on. It is quite mind-boggling. It is the stuff of science fiction, some of it. And with that, I'd like to welcome Sudha back to the stage and say again, welcome everybody. Thank you so much.
Well, so we're here to learn all about big data from a slew of experts. We're very excited at the lineup of speakers we have from industry and academia. We have various industries represented. Large companies like Optum, startup companies like Tuple Health, etc., and also some of our very own people, professors or also entrepreneurs at the University of Arizona. Thank you very much, Andrew, for that kind introduction, and also Len, we appreciate having you here. Thanks, Paolo. So I'd like to start by introducing our first speaker of the day. Everybody here has probably heard of the Watson system from IBM, the system that the artificial intelligence system that IBM developed that participated in Jeopardy and actually ended up winning Jeopardy. Well, our first speaker, Dr. Basit Chaudhry, is who I think of as the medical brain behind the Watson system from IBM. But Dr. Basit Chaudhry is the founder and CEO of Tuple Health. He is an internal medicine physician and a medical technologist whose expertise focuses on healthcare payment, clinical service redesign, and the use of data analytics to improve clinical and financial performance in healthcare. Last night at dinner, we were asking him if the competition in Jeopardy with Watson against the humans was all set up, and he said absolutely not. And I asked him if he was nervous about the competition when it went into Jeopardy, and he said yes, because they didn't know how well it would work, but it ended up working really well. So Dr. Chaudhry used to work with IBM at that time. Now he has decided to become an entrepreneur by starting his own company called Tuple Health. Prior to Tuple Health, of course, he was a medical scientist at IBM Research, where his work focused on using data analytics and information technology to drive innovation in healthcare. His work focused on improving healthcare productivity, ACO and PCMH implementation, optimizing workforce utilization, and improving the quality and efficiency of care. In addition, he worked on developing IBM's private and public sector business strategies for the healthcare industry. After finishing his medical training in internal medicine, Dr. Chaudhry completed the Robert Wood Johnson Clinical Scholars Program at UCLA, earning a Ph.D. focused on biomedical informatics and health services research. He has worked in the internal medicine department at UCLA and as a research scientist at the RAND Corporation. He has provided expertise to the U.S. Department of Health and Human Services and the Institute of Medicine, and served on a working group of the President's Council of Advisors on Science and Technology, co-authoring its policy report, Realizing the Full Potential of Health Information Technology. We're very honored and pleased to welcome Basit.
When I first started practicing medicine, one of the things that became very evident very quickly was how shattered the experience was. And it was a very profound experience going through this sort of divergence in the work and your aspirations that quickly becomes apparent. And on one fragment, it's just the best thing you could ever do. I mean, just the most meaningful thing, the kind of thing that you've been thinking about your whole life of dedicating towards. And that's really sort of the part of it where you're working with patients. And it's a very, very wonderful experience, very humbling in many ways. There's another fragment to it where it's just absolute chaos, because you feel the entire system is essentially working against you doing what you're hoping to do for other people. And that's very, very dispiriting. And I think this is kind of the state a lot of clinicians find themselves in right now. I think there's this break, this schism in almost in your identity. That there's these two parts to yourself, there's these two parts to your work, and you just cannot put them together. You know, in a way, I think practicing medicine now is almost being like Alice, and there's Humpty Dumpty just sitting on the wall. And no matter how hard you try, you're trying to reassemble this precious thing, this thing that you love and that you care about, this thing that makes you laugh and you find humor in because it's human and it's alive. But no matter how hard you try, you just can't put those shattered fragments together. And for a long time, I know, personally speaking, you just kind of go through this and you wonder, well, when is this going to change? And right now we're sort of inundated with change in healthcare. I think it's just absolutely fatiguing and overwhelming, and it's sort of exciting, and you want to pull your hair out. But for a long time, I think, I just want to have people sort of recall this. For a long time in healthcare, it felt like we were kind of in stasis. And it really wasn't clear if the system was going to change. So the question kind of morphs. It goes from, when is this going to change? And then you start wondering, will this ever change? Like, will this ever change within the scope of my professional life? And that's a very, very daunting, humbling question. And something I thought about a great deal. Then suddenly that moment appears, and we're sort of living it now. And it's just amazing. When you take a step back, when you think about, 17, 18% of the entire U.S. economy is just being completely transformed, right? And that's amazing. I'm constantly astonished by it in the sense that we have this opportunity now, right? When you think back, sort of so many of us, it's funny, and one of the things we spend so much of our time doing is just working now. And we have this opportunity to think back and look at what do we do with our work lives? What do we look at that proportion of our time here where we spent sort of on professional services? And this moment's now arrived in healthcare where we can really change this world. And that to me is a very humbling experience I feel a great deal of gratitude for. And I know for many of you, you're really the reason why this has happened. Right? There's a feature of sort of healthcare reform where it's a law, it's this and that, but overall, it's so much more than that. It's just this mass conflagration of change. And I think everyone should take a step back and think about that, and think about it often, because it's people you people, people in healthcare, people outside of healthcare who are now bringing their expertise into the field, who are really making this change possible. And for a long time, there was no guarantee that we were even going to have this opportunity. Now, there obviously are enormous changes, and I think healthcare and using healthcare data productively, efficiently, and in innovative ways is one of them. Right? So there's no question that there's a lot to be done, and I think that's why we're assembled here, to really engage in that discussion and see how we can work together to move things forward. Right? And I think for many years, and this is part of the excitement of the current environment, there's this entire conversation going on in healthcare, well, we just need to get the data. Right, particularly clinical data. And if we can just get the data, then entire new worlds of possibility will open up. Right? We can change the way we pay for care. We can make it more humane. We can make it safer. We can make it higher quality. Right? We just need to get the data. And I can't tell you how many times I remember hearing that exact phrase. And here we are. Right? For the first time, we have data at a scale that we could only imagine before, particularly on the clinical side. And we've gone through this massive period of expansion and adoption of electronic health records in particular that's really have changed, when we think about data in healthcare, it's completely changed how we can think about it. And that's tremendous. And that's, again, part of the opportunity and part of the progress that we've made. And I think it's important to remember this because I think oftentimes in healthcare, we wind up focusing a lot on all the problems and not really thinking about where we're making progress. But at the same time, when I talk to people, particularly people who have made large-scale investments in information systems and really made a commitment to improving the system, one of the things that seems to be very resonant and echoes in these conversations is this really that change we were hoping to see? Right? We talked about years and years about getting data. Now we have it, but is this really what we wanted to be doing with it? Is this really the scope of possibility that we wanted to engage with? And in general, I think many people are really wondering whether or not we're doing what we should be doing. And I think one of the recurring themes that you hear often is, the data is just not actionable. That's probably one of the single most common things I hear when talking with people, whether that's payers, providers, purchasers. The data is just not actionable. And that's really one of the things I really want to talk about today, because it's great to have digitized this information that we had in healthcare that was on paper. But the key question is, how do we use it? How do we use it to improve people's lives? Right? And a lot of that is that's a lot of sort of the context for this whole notion of being actionable. Right? That's really what people are trying to get at. And I think part of this conversation and part of this, I don't know if disappointment's the right word, but at least longing for something different, I think is set against or resonates against this entire sort of age of, quote unquote, big data that we live in, where innovation is just breathtaking and everywhere. So I think for many people in healthcare, you do things like, obviously use Amazon, and it's just amazing what can be done. Or say take Netflix, right, where 60% of all the movies that people select on Netflix are essentially influenced by their recommendation system, right? So compare that to the kind of decision support systems we have in healthcare. The gap is just enormous. And I think people really feel this. They might not be fully articulating it in their minds or in their voices, but there's this gap between the art of what's possible today that people see in their everyday lives in things like Netflix and Amazon, and what they're actually encountering in their work within the context of healthcare. And it's that gap that we have to fill if we really want to change the value equation in healthcare. I remember one of the first patients I ever took care of in a longitudinal fashion over time was this really wonderful fellow. He was a diabetic, and he had hypertension, and his blood sugars, they weren't doing so well. And it was getting to the point where it looked like we were going to have to start him on insulin. And that's just a profound life change. Right? And it's one of those things where there's, a set of patients who this happens to where it just completely transforms their lives. Right? Because the thought of having to take insulin on one level is just so scary that it really makes them reevaluate what their goals are for their own health. And this gentleman was one of them. He was an elderly fellow, and he's just wonderful. And so here we had this level, this moment of engagement where, it was related to these data that he was getting back. And again, this was sort of in paper form at the time, but he could look at his blood sugars and his hemoglobin A1C, and he was concerned. And he completely changed his behavior. Right? He became much more proactive in taking care of himself. He started exercising. He started asking a lot of questions. And it was funny because it was at that point where the system and what I was doing, it felt like it was falling apart. Right? Because as he was becoming more engaged, I couldn't help him in the ways that I wanted to, because he was again, wonderful elderly fellow. He walked with a cane. By the time he'd sit down in the exam room, we had maybe 7-8 minutes to talk, and he had all these questions, and they were wonderful questions, but I just couldn't answer them. Right? And it was one of the funny things about this, one of the difficult things about this, is I constantly felt I just wasn't doing enough for him. And one of the things that made this hard, in a way, was that he lived in the immediate vicinity of the clinic. So I would see him walking all the time as I was going into work. And on one hand, this was great because here he was, the engaged patient, actively participating in the kind of behavioral change we need to take care of chronic disease. And on the other hand, I felt like I was constantly failing him. Right? Because the type of coordinated, high-touch care that he needed, I just could not provide. And I think this gets at this gap between the art of what's possible in areas of technology and data that are surrounding us in society and where we are now in healthcare. Right? Because in order to help that gentleman, we need to fill that gap. So this is one of my favorite places in the world. It's one of my favorite buildings in the world. I think it's endlessly fascinating. And this is an example that the technologist Kevin Slavin talks about, and I wanted to share it with you today because I just think it's just a tremendous, illustrative example of where we are in the world. So this very special building is 60 Hudson Street. It's in Manhattan. It's in the downtown section of Manhattan. Now, part of what makes this building so endlessly interesting is how expensive it is. Now, real estate in this building is inordinately expensive, even for Manhattan. Right, even for downtown Manhattan. And if you're inordinately expensive for Manhattan, that's really expensive. Right? And if you look, if you walk just even a couple blocks away, the prices in real estate fall dramatically. Right? So it's not even just an area effect. It's this building that's been chosen, so to speak. Right? And what makes this building even more interesting is that no one lives here. Right? In fact, no one really even works in this building. Right? It's worth hundreds of millions of dollars. It's some of the most expensive real estate in the world, and no one lives there and no one works there. So why is that? Right? What is going on in this building that makes it so special? Right? When they refurbished this building, the architects gutted it and put reinforced concrete and steel on all the floors and in all the walls. Right? So you have this building with these enormous investments have been made, and no one lives there, no one works there. Right? So who lives there? Right? Algorithms live there. Right? Because this very special spot in Manhattan is where the internet physically comes up into the island. Right? There's 2 places in Manhattan where this happens. This is one of them. This is the place closest to Wall Street where that happens. So if you're an algorithm and you trade commodities, or you trade stocks, or you trade financial instruments, this is where you want to be, right? Exactly here. Because we tend to think of the internet as this kind of ephemeral, up in the cloud, we have it in our pocket, mobile devices. It's become this ethereal thing, but it's not. It's physical. It has a reality. And this is that reality. So the closer you are to this reality, to this building, to this special spot, and you're an algorithm, the faster you can be. The more trades you can execute, the faster you can execute trades. And this is literally worth billions and billions of dollars. So if you take a step back and think about it, think about some of the questions that sort of haunt our lives, like how are we going to retire, right? This is how we're going to retire. It's literally millions of bots running in a building, interacting with each other, outside of human consciousness, outside of human curation, outside of interpretability. Right? And that's the world we live in. And that's why when I think of big data, I think of this building. and what's going on there. And again, think about that reality and that level of sophistication and what we're doing with data in healthcare. This issue of what is big data is one that's constantly described, and I think the term is problematic, but it's become part of the conversation, so I'll use it. And there's a couple of things I wanted to highlight about it. So I think the first thing about big data, and again, sort of, it's a newer concept within healthcare, the issue of just the size of the data or its volume, I think in many ways is secondary. What's really important in the healthcare context is its variety. And I think this is the biggest change we're seeing in data in healthcare, and part of the potential that we're not really taking advantage of fully. Right? We're seeing a tremendous variety of data, and that's really going to be important in driving value back into the healthcare industry. Again, volume is key, and this is clearly growing. But compared to other industries, the amount of data that we have right now actually isn't very high. That will change in the future, but in current state, it's not really that big of an issue, particularly with modern infrastructure. The velocity of data is important, particularly we're moving from working with data sets to data streams. Veracity is another big issue. Healthcare data in general suffers from severe data quality problems. And again, this is an area where I think we can really learn from colleagues in other disciplines and industries, such as computer science and the IT industry as a whole, because a lot of the data that people work with, as mentioned before, and so that we'll talk about this later, it's low fidelity data, the quality is not great. So there's a whole set of techniques which can be brought to bear inside of healthcare to correct problems like that. But again, we're not taking advantage of those things. And I think ultimately, when I think of big data, I really think about value, right? And this really means, how do you align a set of business priorities, clinical priorities, with the right set of analytic techniques and algorithms, the right frameworks, and the right people who are really going to tackle that clinical problem, that organizational issue, and align it with these kinds of sophisticated techniques to produce new levels of value. Right. Now, ultimately, I think the tools, and I think the conversation around big data involves, a lot of these kind of focuses on technology, and they're important, but they're not enough. And I think part of the conversation around sort of big data in general is sort of, there's a point of view on this, that what really matters is just getting data, and you don't really need to understand a great deal about its context, particularly the domain or the industry that it comes from. So data is data, and it speaks for itself. And I just fundamentally disagree with this. Right? There's importance in the tools that are emerging, but the tools themselves are just tools. And what really matters in producing value is really aligning a point of view on healthcare, particularly for our field, and a deep understanding of that with a deep understanding of what the algorithms can do and what the technology can do and the capacities of the data. And it's really that alignment where I think we get new kinds of value creation. And that's an area we're still really only in the infancy of in healthcare. So where are we today in healthcare? And this is the dashboard, and I'm just using this as kind of a summary because I think this is really in many ways where people are trying to get to within the healthcare industry. Right? So if you look at really innovative people in the delivery system, whether it's organizations adopting new payment models like ACOs, organizations moving to global capitation, whatever it is, this is really where people are. And this dashboard isn't specifically from healthcare, but it's pretty typical of the kind of things people are trying to do with analytics right now. So what does that look like? Really, what it is we're looking at key performance indicators that in healthcare are often referred to as quality metrics. Right? We're describing them largely in different kinds of percentages, and then we're doing some benchmarking around them. And this is really, in many ways, the current state people are hoping to get to. Right? And so this kind of bridge where people have made tremendous investments in their EHRs, and now they're trying to sort of get to this state where they can manipulate the data at even some fundamental level. Again, these things are all important and they all need to be done, but if you compare this to something like Amazon or Netflix or 60 Hudson Street, it's not even remotely close. And I think one of the ironies that's gone on particularly after this series of years where we've seen really rapid increases in electronic health records is that healthcare as an industry, we're still 20 years behind other industries. Right? We're now in the phase where we're digitizing the data, but that whole phase of then understanding what do you do with the data and how do you map it to processes, how do you change those processes, and how do you ultimately produce business value through it, we're just in the infancy of that journey. And it's really, again, that gap is significant. But again, if we look to other fields and look to other industries, we can do a lot to diminish the lag time in our learning. And I think that's a critical thing we have to do. And one of this gets back to, I think, it loops back to the question of how do I make the data actionable, again, which is, it's such a commonly, voiced phrase now in healthcare. And I think a lot of this gets to, if you're just using, these kind of dashboards and these kind of descriptive statistics and benchmarking, it always leaves the question of, well, why is this phenomena happening, right? So say, you have a narrow network and your leakage rate from that, say in an ACO is say 40%, 45%. That's good, and you can benchmark yourself against, other ACOs or other narrow networks if you're a payer, right? But the question then becomes why? And the other question is, what do you do about that? And those are really the key questions, and we're not getting to those questions and those answers when we're just sort of moving horizontally in this world of quality metrics, descriptive statistics, and benchmarking, these basic business intelligence tools. Right? So again, we have to get past this phase, but this isn't enough to really drive value. So, one of the biases I think we often have in society, and I think we see this in healthcare, is we have this notion that if you just give people the facts, they're going to change. Right? That's what we need. We need facts. And, that was kind of the underlying theme of a lot of the conversation around medical informatics and I think healthcare information systems and data over the past, 10, 20 years. That, we just got to get people the data and then things will change. But facts are just kind of, they're kind of there. They're just kind of static things like these birds on these wires, right? And you can count the number of birds. You can figure out what proportion of birds are on the curved parts of the wire, and what part are on the straight part, what part are flying, what part are landing. That's all they are. They're facts. They're things we can count, we can look at. And what really matters in driving value is behavior. And if there's one thing sort of I'd like everyone to leave from my talk and the opportunity we have right now in healthcare to do things differently, to close this gap between what we're doing right now and other industries, is that I think what makes this era of data different is that for the first time, we have the ability to gain tremendous insight into behavior. And that's the behavior of people, that's the behavior of organization, and that's the behavior of markets. Right? That's what they're doing in 60 Hudson Street. That's what Netflix is doing. Right? When you're recommending 60% of all the movies seen that viewers are watching, in a way you're curating the culture. Right? You're curating behavior. In a way, you're making profound statements about the nature of art and its possibilities. Right? But that's what the change is right now. And that's why I think, while the term big data might be problematic, this isn't simply a matter of terminology or marketing or anything else. There is fundamentally something different going on now. And I think that difference is about behavior. And I think this is particularly critical in healthcare because we've known for decades now that the vast majority of differences in outcomes for patients aren't related to the formal medical system. They're related to different kinds of behavior. They're driven by social determinants of health that operate within large-scale systems like education, nutrition, violence. Right? They're things that happen at much larger scales and scopes than what happens within the context of a clinic visit. And I think, that was part of, you don't really realize this, but, when I was trying to take care of that elderly gentleman and trying to engage him, I was trying to engage him at a level of, or I needed to, a scope that was far outside what the walls of an office could contain. Because they really were about questions about behavior. And right now, we have the opportunity to do that in healthcare. But to do it, we have to close that gap between where we are and where state-of-the-art is in other areas. So let me give you another example. Many of you might be familiar with this. This is Candy Crush. This is the video game. This is another really fascinating, moment in our culture and our technology. Right? So for those of you who aren't familiar with this, the object of Candy Crush, and I'm no expert, basically you want to line up this candy fruit in a row. That's basically what you're doing. And here's the kicker. Every day around the world, about 100 million people play Candy Crush. Right? It's one of the most popular games for mobile devices in the world. 100 million. And it's not just 100 million people. The company who makes this game, King, it's a Swedish company, has only recently started to try to crack the China market. Right? So think about it. You have 100 million daily users without a huge presence in China. Right? If you have 100 million users outside of China, you're pretty busy. Right? Things are looking pretty good. And here's the other interesting thing about Candy Crush. They've always been hugely successful. But their business model is pretty interesting because it's a freemium business model. And the term freemium is again kind of jargony, but it does describe a relatively new phenomenon in business models. Literally, what King does is it gives this game away for free, right? You don't have to pay for this game to play it, right? So how does that work, right? How does a company stay in business? And even better, King earlier this year had their IPO. They sold some small proportion of the stock in the company, and after the first day, the company's valuation was $6 billion, right? So how does this work, right? Lining up candy fruit in a video game that's given away for free leads to a market valuation of $6 billion. And $6 billion is a big number even in healthcare, which means it's really big, right? $6 billion would be a pretty good-sized hospital. It's true. So how does that, and now I think many of you who sort of lived through the dot-com era are probably thinking, oh, true, right? I don't want to talk about sort of, is King worth $6 billion? That's, I think, a peripheral question, but the fact is, they are not pets.com, right? They, last year they made $1.9 billion in revenue, right? That's not bad, right? That's a lot of money. Again, that would be a good amount of money for a hospital to make, so it's a lot of money. Right, so how does that work? How do you give a game away for free and make it's $1.9 billion with a market valuation of $6 billion? Right? And the way they do it is that they've learned how to sell services and tools within the context of the game. So if you want to play Candy Crush on the free model and you run out of lives, you have to wait 30 minutes before you can play again. Well, you know what? Some people don't want to wait 30 minutes to line up candy fruit. And it turns out a lot of people don't want to. Some people want to buy more candy fruit lives than what you can get on the free game. It turns out a lot of people want to. And all these little microtransactions, that's part of the business model, it adds up to a lot of money when it's done over 100 million lives. So when you step back and think about it then, how does King do this? How does it work? Right? So when you run out of lives in the free model, why do you have to wait 30 minutes and not 20 or 10 or 15, right? When you look at that little orange cough droppy thing, why is it that shade of orange, right? When you're selling, when you're getting people to give you real money for digital trinkets, how do you do that, right? That's not easy. Like, how do you even do product development? It's kind of, live in this world of complete abstraction and fiction. And the way they do it is through data, right? Every interaction you have with this system, I'm sure there's dozens of machine learning algorithms which evaluate consumer behavior. So in a way, what Candy Crush isn't even a video game. It's almost like a survey. Like, I'm sure many of you people here in this room work with paper surveys or digital surveys. It's really not that different from a survey. It's a data collection instrument. Right? It's a sophisticated data collection instrument that's sort of fun to use rather than filling out boring questionnaires. But that's what it is. So in a way, that makes you think, is Candy Crush even a video game? Is King a video game maker? Right? In many ways, they're not. They're a data analytics company. Right? And what are they analyzing? Right? They don't care about the data just for the sake of the data. They've created this tremendously sophisticated instrument to gain a level of insight into consumer behavior that we've never had in the history of capitalism. Right? So just think about the gap between that level of sophistication and looking at consumer behavior and what we're trying to do to understand consumer behavior in healthcare, particularly as healthcare moves from an enterprise business, an enterprise-based industry where it's largely business-to-business transactions, to this whole new world where we're trying to understand how to reach out to healthcare consumers. Just think about the gap between that level of sophistication. It's astonishing. So I'm going to go through a couple examples of some really exciting new projects that I'm personally working on. Again, these are just meant to be illustrative. But one of them, we've developed a really, I think, promising partnership that we're starting with this really innovative multi-group practice. It's several hundred physicians, and they're committed to moving from fee-for-service to full-risk global capitation. They're a Medicare ACO. They have their own insurance product, and they're currently looking at developing a Medicare Advantage product. But one of the real problems we have in healthcare right now is just the tremendous overuse of emergency room visits. And again, what I want to get here and illustrate is this whole notion of how do we start looking at behavior in more granular ways by using different kinds of techniques and frameworks. Right, so 50 to 75% of emergency room visits are thought to be unnecessary. Just think about that. Right? And if we sort of can chat offline about some funny stories I know about sort of emergency room use in Tucson, in Phoenix, actually. And when you look at that, what does that translate into? Every one of these unnecessary emergency room visits, if you look at the delta between the average cost for a clinic visit and the emergency room visit, it's $580. Right? Every unnecessary transaction is worth $580. Now, I know a number of you are from the business school here, and I'm sure light bulbs are going off. Like, wow, that's an opportunity. And $580, that figure, that statistic, is why roughly $2.3 billion of private equity money since 2008 has been invested in urgent care clinics. Right? We have this tremendous rash of urgent care clinics pop up all over the United States, and this is the reason why, $580. Now, working with this group practice that we've partnered with, one of their priorities is to try to really optimize the way they deliver care by decreasing unnecessary costs. And the emergency room is one of the areas we've targeted. So we're also looking at hospitalizations, readmissions, and network leakage is another area we might be looking at. So the question is, how do you do something differently about this? Because in current state, people are looking at benchmarks and dashboards and things like that, and they're really trying to fill gaps in care. But the problem with that approach is essentially the utilization and expenditures have largely been sort of already sunk before you're doing anything about them. So we have a 4-part solution to this, and I'll just go through this quickly. Oh, actually, let me take a step back first. So when this whole issue about sort of trying to solve this problem, it was one that's come up in the past before, and this gets back to how do you start coordinating care more efficiently. And one of the things that always winds up happening, or recurrently winds up happening, as you try to scale these services for chronic disease, and again, a lot of the primary driver for unnecessary emergency room use is really inadequate care for chronic disease longitudinally over time and lack of care coordination. One of the things that we wind up doing in healthcare is we take nurses, it's most often nurses, that's why I cite this particular part of the workforce. We take these unbelievably talented, energetic, parts of the workforce, and we essentially have turned them into call center workers, right? And this is a lot of how chronic disease management has been done in the past. And I think we've made some progress here, but again, these models are really, coming back. And again, when people try to scale them, this is one of the things that invariably happens. You only have so many nurses, and you have a fixed set of resources to distribute that nurse workforce over. So what do? So this is what we're working on. So in part 1 of this, we're working on developing algorithms that develop more finer-grained risk prediction and population stratification. We're using a variety of different data to do this. That's clinical data, claims data, patient satisfaction data, and operational data. We're developing a framework that combines techniques from machine learning, operations research, and health services to do it. And it's interesting, if you look at risk prediction in healthcare, the dominant model that CMS uses, this is particularly true for Medicare Advantage, it predicts around 13% of expected expenditures and accounts for about 13% of disease severity. So there's a tremendous amount that needs to be done in this field. The second thing we're doing is we focus a great deal on engineering workflows, and I think particularly when you look at developing these positions of care managers, workflows are key because they're new. So if you don't think about how do you map the analytics to a process, you're not going to drive value. Third step, once we've done this, what we're working on is really figuring out how do you optimize the use of this workforce resource, right? The problem of costs in healthcare is really a problem of people, right? 65% of all spending in healthcare is on people, right? So we have traditionally not thought carefully enough about how we use people. And when in this current state where we're going to have a situation where we have more and more fixed resources to develop and allocate over populations, that really becomes an optimization problem. And analytics, I think, are going to be fundamental to that. And finally, we're bringing this all together in a platform that provides new communication tools to enable high-touch care. A second example, this is a project we're doing with a national payer. Access to care is a huge issue. It's very difficult to see physicians, in particular in Boston right now. To see a family physician or a primary care physician, the wait is roughly 66 days. Here's another dimension to access to care that's a big problem. You know, we're constantly telling patients to change their behavior, but for a lot of patients, you know, they live in what have been described as food deserts, right, where they literally cannot buy good food. Right? So how do you possibly take care of patients when they can't even, you know, get decent food to buy? So we're working with the payer to do a project where we're using GIS-coded data for disease prevalence, physician services and healthcare services at a GIS-coded level. And we're marrying that to classification algorithms, recommendation systems, and optimization techniques to try to figure out, on a population health basis, how do you optimize the allocation of different kinds of resources. This is an exciting project, and we're just starting on this, but it's a lot of fun. So again, I want to bring us back to sort of where are we today with data? How do we close that gap between where we are now in healthcare and where we are possible? And some of the examples that I've talked about, it might seem very far afield from things like dashboards and quality metrics and benchmarking. But again, that's happening all over the world right now. It is imminently possible to get there. That's what's happening in 60 Hudson Street. Every time you walk into a Target, it may seem like, oh, there's all these products there. You ever stop to think, why are they there? Like, why is this product on shelf 2 rather than shelf 3? Right? And part of the reason why they're there is that Target kind of operates like Candy Crush in ways. Right? The reason why the products are in these different aisles isn't an accident. Right? There's sophisticated logistics and algorithms that determine how to optimize shelf space. Right? So what Target says to their manufacturers, like, how do you decide between where to put a Target branded product versus Procter & Gamble products, right? What Target says to their suppliers is this: look, in downtown Tucson, we'll give you 10 feet by 10 feet of prime shelf space. Here's the data on your sales. You make it work, right? So in a way, the shelf space is the limited resource. Target provides the suppliers data, and part of their business needs to be, how do they optimize it? And if you think about the way, this might again seem far afield from healthcare, but if you think about these transitions we're making, particularly in payment away from fee-for-service, what's happening? Right? Payers are telling the delivery system, look, we'll provide you with data, we'll provide you with essentially a fixed set of resources. You figure out how best to take care of these patients. And this is the difference between what we're doing now and what we did in the managed care era. Right? This is the whole shift in accountability. So in a way, when we think about transitioning from volume to value, we have to do exactly what Target did. We have to determine where to put the little red dot. With that, I'll take questions. Thank you.
I have a question for you on the Watson thing. We read a lot about it and what's happening at Sloan Kettering. Are we starting to get outcomes data on that yet? I saw that it is proving to be worthwhile, or is there still a lot of work needs to be done?
Yeah, Pat, those are good questions. I'm just hesitant to sort of speak to that because I'm just no longer working with the project, and this changes so rapidly. So I can't really speak to that with a great deal of insight.
Hi, I'm Richard from Banner. And so I noticed the phenomenon with Target that you're kind of speaking of is kind of the head of the dragon, and the tail of the dragon is where places like Amazon kind of were able to prosper. Do you know of anything within the healthcare system where they're trying to take advantage of the tail of the dragon, which is the opposite of just the head part there that you were kind of focusing on?
I'm sorry, I'm by head of dragon, tail of dragon. I just want to make sure I understand your reference.
So the most popular items is designated by target would be the head of the dragon and receive most of the, in fact, that's probably where they get most of their profit from, is from the head of the dragon, and they're therefore placed in prominent places for buyers to consume.
Yeah.
But Amazon took advantage of, for example, the tail of that dragon. So all the other stuff that isn't a focus. Is there,
Yes.
is there anything in the healthcare area that is trying to take advantage of that? Kind of the opposite of what you were saying.
Yeah, I think that's part of what we're working on with that payer and that GIS coded data. Essentially what we're trying to do is sort of do something like that where, for patients, for policymakers, for provider systems, you can get a sense through this algorithm, these set of algorithms and recommendation systems for a particular population and location. These are the set of assets that are available to deliver care. So if you do live in a food desert, you can then figure out, okay, well, where could I possibly get food at a particular price, and how do you sort of put those dots together? So that's one example of something I can think about. But again, I think these things are very new to healthcare, and they're very promising.
Thank you.
Thank you for your talk. I'm a librarian, and I'm very interested in your behaviors slide because I study information behavior and connecting information with people. And there's this whole back end of, I work with information management folks and folks that build everything for us, but where is the connection of the people that are on the front lines providing that care and providing that information to the patient, and the back end folks that are analyzing it and putting it together so that they are getting the appropriate care? And with all this personalized medicine and healthcare and different things that are taking off at the same time as big data, I'm just interested in where is that information behavior being studied and applied to healthcare?
It's a very, very good question. I spent some time, actually when I was in medical school at McMaster University, which is one of the birthplaces of evidence-based medicine. There in Oxford were really the two places that developed the movement. And one of the things I was really struck by when I was there was how actively participatory the librarians were. And again, this was sort of before the internet really exploded. So a lot of the work was manual curation, but it was just a critical set of resources. And I think you're really asking a question of how do we curate knowledge in our current information age. And that's a problem. It's a very, very difficult problem. I wish I had a good answer for it. But that was part of what my prior work, particularly with Watson, was really focused in on. And I think we're going to have to figure out some mix between human services and automated techniques to do that. And what that mix is, it's going to be really difficult. I think one of the productive ways to think about this is, in the past when we've thought about division of labor, we thought about it in terms of specialization of different people doing different tasks. I think a big part of this global knowledge curation challenge is going to be how do we rethink division of labor, and that division of labor really depends on what do people do well and what do machines do well. And I think that's part of what we're trying to negotiate right now in the culture.
Hi, I'm Kim Shea, and I'm from the College of Nursing at the U of A. And I'm thinking about your analogy, your candy, whatever, king analogy, because I play that Candy Crush, thank you. I play that game a lot.
There you
now,
go.
I am not one of the people they make money off of because I'm cheap, and I won't pay all those extra things. Consequently, I'm not very far in my leveling. However, as nurses, my analogy to healthcare is, as nurses, we try to educate our patients, help them as physicians as well, to be preventive in their healthcare, to be the me of Candy Crush that doesn't use the extra things to spend money on because I don't need it. And that's one of the things I see in healthcare is often we're very reactive rather than proactive with our data analysis. And in my limited knowledge of big data is it's very good at descriptives, but we haven't quite figured out how to make it predictive. And so can you speak to that as to how you see that going forward and how you see healthcare working more to plan for positive outcomes than to plan for the problems or the negative outcomes?
Yeah, again, that's a terrific question, and one that resonates with me very personally, because I think those are really great challenges. You know, what you said is really quite interesting, because I think you've gotten at part of the gap that I was describing. So it's interesting when you think about big data, you're thinking about it as being reactive and largely descriptive. That's the way it's being articulated within healthcare right now, because largely what we're doing really is collecting data, summarizing it, doing some benchmarking, and that's that. Right? And the problems that we see essentially, like, you know, one of the big things systems are focused on now is payment models change, and we move towards some kind of quality metrics that are incorporated into the payment models, that they want to close gaps in care, which really sort of is performance on these metrics. And the problem with that is that it's still reactive. So what's, I think, very problematic in healthcare right now is we move to these population health models. It's great that we're moving away from individuals and developing scale, but it's still too reactive. And that's part of the project that we're working on with that group practice. And they're really innovative, and they want to move to full risk global capitation. Right? So for them, they can't be reactive. And that's why I think the starting point of what we're doing is risk prediction and population stratification, and then developing optimization algorithms to say, okay, for this subset of patients, these are the problems that they're likely going to have, and this is how we should use our skilled health professionals to engage with them, and these are sort of the workflows and processes. And that's really, I think, the end state we have to get to, because until we do that, we're not really managing healthcare, we're just reacting. And management and planning is something we just have not done, because we're constantly waiting until a symptom emerges or a problem emerges.
Hi, I'm Joe from Dignity Health. I was going to ask you a question, but the first thing I wanted to ask you is, I see all your color of orange in all your slides. What's the correlation between orange and behavior?
That's a good question. You'd have to ask King. They'd have the answer to that. I just like orange.
Yeah, it's cool. I do too.
There you go.
Tell me about how an integrated delivery system like ours, projects you're working on, U of A working on things in analytics, to correlate health outcomes with cost, you know, the big kind of things we need to figure out, just doesn't stop as individual science projects. You know, it's proprietary, it's happening in Boston, it's happening with consulting, it's happening at our IDN, it's happening at another IDN. How do we scale that into healthcare?
Yeah, that's, again, another tremendous question. I think one of the reasons why healthcare is so inefficient is that essentially it's organized around this kind of traditionally this almost guild model that's almost out of the 19th century. We have these small firms, they work in this idiosyncratic fashion. And it's often said that healthcare isn't innovative, and in many ways that's true. In many other ways it's totally untrue, because where we're really not good at is scaling innovation. And I think for, you know, a system like Dignity, such as yours, it's a huge challenge. Obviously, for your geographic scope, just the scale, the number of patients you deal with, you know, your total book of business, it's very significant. So scaling is constantly something we're struggling with, and I think you see this in other industries also, because all of our techniques and methodologies to scale, they largely come from manufacturing. So one of the interesting things in healthcare right now is that we're engaged in an experiment of trying to develop scale and knowledge-intensive human services that I don't think other industries have really even attempted. So in a way, we're sort of pushing the envelope on these things. But I think the key thing in achieving scale is really, how do you derive value from data, and not just on benchmarking and description, and then map that to new kinds of workflows, and then develop a new set of communication tools to support that. And that's what we're trying to do with that multi-specialty group practice that's moving to global risk cap, because I think you need those 4 pieces that I described to really do that. And then I think you can start achieving really interesting scale by using a host of techniques from operations research in particular.